Good morning. Thank you for joining us here on SL. We want to welcome you to our April Saturday Educational Speaker Series. We have Dr. Jimmy coming here. Tell a little bit about who you are, what you do, or thank you for your appreciation for your help this morning.
Yeah, I'm really excited to be here. I get to just come and talk about my favorite subjects, which is vestibular and headache therapy. So I'm Dr. Jimmy Pang. I'm a physical therapist based here in San Diego. I have a mobile practice, so I don't have a physical location, and I just continue to work with you. I think unlike most physical therapy practices, I pretty much exclusively work with dizziness, vertigo, and headaches. So I don't really see too many people with back pain and elbow pain and orthopedics. So I know a lot of clinics out there, they have a vestibular therapist, but a lot of times these clinics are more ortho facing forward, and I think that's what really differentiates me from my practice from some of these other ones. So today's presentation is actually going to be pretty demo heavy. So it's going to be pretty interactive. And my goal today is not just to explain like kind of how we approach headaches and dizziness, but I really want to show everybody what that whole process looks like from beginning to end. What am I thinking when I see someone who has headaches or dizziness? What am I doing to hone down on what I need to target, and what exercises or what treatments are we using specifically to take care of that? So just want to give a big round of applause to also our San Diego Grand Prix staff, because they are going to be patient dummies today for all my demonstrations. So wish them luck. Hey, so welcome to my talk. So today we're going to be talking exclusively about headaches and dizziness. Headaches and dizziness, these are kind of vertigo, and oftentimes these are thought as separate buckets, but there's actually a ton of overlap. And then today we're going to see exactly why that is and how we're going to go ahead and approach these things. But let's first talk about how prevalent these disorders are. So anyone in the crowd, or if you're on Zoom, you can type in the chat. How many headache disorders do you think exist? And guesses? Yeah, take a guess.
30.
30? Okay, if you're 30, I don't know. 50? Okay. So the answer is 300. Yeah. So there are actually over 300 headache disorders that exist. Hi, welcome. Yeah. So yeah, there are 300 headache disorders that exist, and then wait for the settle first angle. All right. So yeah, there are over 300 headache disorders that exist, and then I know a lot of us are already seeing neurologists, brain injury neurologists, but there is headache neurology, and that's a very different field. They are fellows of headache medicine, and then so we have 40 million people living with headache disorders in this country, but we only have 900 headache physicians in the country. So that's about 1 per 44,000. One headache physician, one headache fellow per 44,000 headache patients in the country. So we talked a little bit about headaches, and then a lot of these headache disorders also involve dizziness and vertigo. Just want to highlight a few. So migraine, that's probably the most common headache disorder is actually tension type headache. But for the most part, those are pretty mild for a lot of people. Of course, there are severe cases, but for a lot of people, the majority, it's pretty mild. They can be self-managed. And then the second most common is migraine. Migraine is the leading cause of why people go see a neurologist. Okay. And then so, like I mentioned, 40 million people with headache disorders. That's a lot of people with migraines. It's mostly migraine. And migraine is actually the second leading cause of disability in the world, just behind low back pain. And then in women under 50, migraine is the leading cause of disability in the world. But because it's an invisible illness, it doesn't really get taken seriously a lot of times, unfortunately. So migraine actually isn't even a qualifying diagnosis for disability right now, with Social Security, disability, long-term disability. So there's definitely a lot of work and advocacy that needs to be done there. Not to mention, I don't think it's a secret that our healthcare system has historically ignored women's pain, right? Women headaches and dizziness, it's predominantly disproportionately impact women, unfortunately. Yeah. I've been getting a lot of men recently, which is really weird, but it's mostly women. And I have chronic headaches as well. But it's mostly women. And then so because of that, the average time to get a diagnosis of migraine is about 7 years. Yeah, 7 years. So obviously that means we don't have enough education, both in the public and among healthcare practitioners right now to be able to identify these. Go ahead. Yeah,
I got a question for you.
sure.
So, when I got shot, I told you I got shot in the head.
Yeah.
And the doctor, I had sort in operation, and they doctor put a metal plate in my head,
Sure.
and I got constant headaches that come and go as they feel you. And when I go to the doctor and my neurologist, I complained to even my primary doctor. So that when I complained to him about these headaches, well, he said that they all say that there's nothing that they can do about it except give me a Advil or a Tylenol, but that doesn't matter.
I would push back against that for sure. Personally, I would. Um, you've obviously had some major trauma to your brain, and that's going to cause headaches very obviously. But headaches are pretty much always going to be multifactorial, right? There are always going to be different contributing factors, and we're going to be talking about that a little bit today. So after your initial brain injury, now you're stable, but after your initial brain injury, that has consequences, cascading consequences, right? Because the brain is maladapted, so it causes issues like neck tightness, and causes issues with vision, causes issues with dizziness, vertigo, inner ear function, right? Once stress, yeah, not to mention, the actual physical thing of the plate in there. So when that happens and the brain injury causes all these things to happen, that can come back and then feed into the headache disorder. Because if your vision and your ears and your neck, they're not coordinated properly, your brain doesn't like that, right? Your brain is having trouble telling where the head is in space. And then what happens is that feeds into more headaches. So there's definitely a lot more to headache treatment than just Tylenol, Advil, medications. We have very good data that for headache, people do best with an interdisciplinary care, right? So going beyond medications as well. Yeah. And then so for migraine, certain headache disorders are going to need more medications than other. For migraine, personally, I work with headaches every day. And when it comes to migraine, I personally prefer my patients to be medically managed as well. So I always tell people with a migraine disorder, the medication is going to get you maybe 60-50% better, right? And then once you're stable, that's when I can come in and we can do this kind of conservative work, get you that extra 25 to 30. Unfortunately, there is no cure, right? So that's where I tell people you can probably get 85, 90%.
That's the same thing they tell me.
Yeah. There's no cure, but that doesn't mean you can't get better, right? So we can definitely increase a person's quality of life quite substantially, I would say. Yeah.
It feels like the headache I get, it feels like a brain freeze when you eat ice cream.
Yeah. Interesting sensation.
Oh, yeah.
Yeah, and then that's
It
another.
only lasts for like 5 seconds.
Okay. Yeah, that's another interesting point you bring up. Headaches. Headaches is a very bizarre world. It's not always. You had a question? Yeah.
When he said that, I was talking to you early,
Yeah.
the thing, when he said the brain, the ice cream, that's what it was like.
Yeah.
So I think it's the same thing, just my way of doing it,
Yeah.
he said it, same thing.
Yeah. No, absolutely. So with headaches, it's a very bizarre world. I think most of us in here have experienced a headache before. But people don't understand just how different headaches can be across the spectrum. There's 300 headache disorders, and they're all unique coming up. And migraine in itself is already very, very spectrum. Like some people, typical complaints are like, I have head pain, I have some facial pain, right? But what we also hear a lot in my work is I hear things like, feel like my brain is swirling, feel like my head is disembodied, right? There are a lot of different ways headaches can present. It's not necessarily just headache pain. It can come with other features like light sensitivity, sound sensitivity. While we're talking about migraine, I might as well talk about some of the more rare presentations as well. So, has anyone here heard of hemiplegic migraine?
What is it again?
Hemiplegic migraine. So it's a migraine attack that presents with one-sided weakness, and it looks just like a stroke, right? But it's actually a migraine disorder because when they do the imaging and they do the follow-up, there's no, there's no obvious, cerebral infarct, right? And then it kind of resolves after. So that's a presentation of migraine. There's something called abdominal migraine. Have people heard of that before? So yeah, stomach. So there's a lot. This one's more in children. There's a lot of interaction between neurons in your brain and your stomach, obviously. So with abdominal migraine, what happens with these a lot of people, mostly children, is their migraine attacks come with a lot of abdominal symptoms, stomach pains, digestive issues, stuff like that. There's another headache disorder that I really like to bring up to people. It's called cluster headache. Who's sort of cluster headache?
That's interesting. How does it help me escape from stomach?
Yeah, so the thing about headache disorders is one, headache is a symptom. So headache is not a disorder in itself. Headache is a symptom. So most headache disorders, especially migraine, most people, the symptoms are concentrated in the head and neck. But when we're going to get into a little bit more, headache disorders and vestibular disorders are 100% a whole body disorder. A whole body disorder. Because you think about it, a lot of it has to do with the brain itself. And the brain is your command center for your whole body, right? So it's not, in some of these rare presentations, we just see those effects downstream. So, with migraine patients, you'll hear actually, before they feel an attack coming, a lot of them will also report things like cravings, right? They'll report things like fatigue, yawning, trouble thinking. And they'll even present with things like paresthesias, numbness, or they'll even present with a common one is increased urinary urgency. Actually, that's one a lot of people miss. Yeah.
My daughter gets auras.
Auras.
She can see,
Yeah.
lights.
Lights and stuff,
and-
right?
Yeah.
Yeah. So that's a great point. So with aura, what happens is migraine is basically like there's too much electrical and chemical activity going on. And for a lot of people, that starts in the vision centers of the brain before it spreads out all over to create the migraine attack. And that's why their attacks are, preeminated by these visual auras. But the thing to remember about this is that also this electrical activity can start in other parts of the brain as well, which is why we see some people with auras, they have aphasia, they have trouble speaking, they have trouble forming sentences, thinking, and then some of these other more rare presentations, you'll hear things like, increased urination, even decreased urination. That's when they know that a migraine attack is coming. So 100% a whole body disorder. Okay. And then cluster headache is one of the most painful disorders known to man. They are described as being more painful than gunshot wounds. And they've also been coined suicide headaches because they're just that painful. So they come in clusters yearly. They kind of come on during a season, like maybe the spring. They'll get these clusters of headaches, very, very painful disorder. So yeah.
It didn't hurt me because my headaches was so bad. I had like nothing. My birth, so my whole body. It wouldn't be all the time, but it would be really bad. I'd have to turn dark and undark, the dark with the light. And everything. My son, so he had those dark sinus sunglasses.
Sure.
That I had a headache and I couldn't. Everything. So yeah, I was just saying it can be worse than any other pain that you can have.
Yeah, exactly.
Yeah. And I got my hip replacement. Nothing. The headaches was so bad.
Yeah. No, yeah, for sure. So there's still a lot of stigma around headache. If you tell somebody, some people, I've had this happen too. You tell some people, hey, I suffer from a headache disorder. This is hard for me. Some people will be like, it's just a headache, right? It's just a headache, right? Headache disorders are not just headaches. They're highly disabling, complex neurological diseases that have implications in the whole body. Okay? So that's why when we see these migraine or headache patients, we really need to be taking a good comprehensive look at everything. We can't just silo ourselves. A lot of physical therapists, they work with headaches a fair amount, chiropractors, and they really focus on the neck. And the neck is important, but it's not the whole picture. And that's really what I want to highlight today. So basically, the point I'm trying to make with all this talk about different headache disorders is that the world of headache is much deeper than a lot of people realize. Most people have no idea just how complicated headaches can be. And we really need to change that so we have more awareness, more advocacy, and so our headache patients have more accommodation so that they can live better lives and get better access to treatment.
Maybe you can also work with gynecologists. When I first got headaches, it was I didn't know it. This was in the 90s. They weren't talking about menopause, so
Yeah.
I got it right around my period. And so I went to the doctor, and he looked at me and he went, "Oh, well, no, it's not." I went, "But yeah, it is." And he went, "Well, no, it's not. It can't possibly be." So I went and I found another doctor.
Yeah, good.
And she said, "Well, there's no real research because they do it on men at that time."
Yeah.
And but yes, it is. We're definitely finding out now that hormones, and that's what goes on with my daughters. She has a hormone imbalance.
Yeah.
Hormones really can affect it. But at the time, there was nothing to read and nothing to do. So most of, they like use of the whole body. That's part of the whole body. And they don't look at females and look at the female differences in terms of parts. Like, they saw that, oh, wait, comes during your period, it comes, connects everything. Nothing's wrong.
Yeah, that's a great point. Half my patients are perimenopausal. It's just common time for things to happen. Headache screening definitely needs to be a part of women's health,
And it wasn't.
and even now it isn't. So they should really be screening. They should really be screening women in their teenage years, even as children. And they're just starting to put out guidelines now that at 14 years of age, all women should be screened for migraine. And sometimes it gets missed. The migraine is so spectral. Some people it's severe. Some people it's like kind of light. But once you start asking questions, it starts to become a little more clear. A lot of people just assume it's normal. Headaches, a lot of headache disorders, especially migraine, are genetic. You'll find like headache families. Their whole family has headaches. Right. So the questions I like to ask is I usually go in and I say, "How bad are your headaches?" And they go, "Oh, they're okay. They're fine." I'm okay. How many headache days do you get a month? Like, oh, I don't know, 2 or 3. Okay. How many days do you not get a headache at all? You're like, "Oh, well, I get headaches every day." So once you dig, you can ask the right questions. Finding out a lot of people have this. A lot of people are suffering in silence. They don't even know it's a big deal. And it's like, hey, you don't have to have headaches 30 days a month. Right? You can do something about that. I unfortunately fall into the guy. I have headaches 30 days a month, but much better place to know. Okay, so kind of moving on. So that was a lot of talk about headaches. So let's just talk a little bit about vestibular stuff. So dizziness and vertigo, and a lot of headache disorders, dizziness, vertigo, they all converge together. Okay, so with the vestibular disorders, who here has been diagnosed with vertigo? Nobody?
Not so, not.
My grandmother was had vertigo.
Yeah.
Worship festival.
Yeah. So believe it or not, that was a trick question. Okay, that was a trick question because vertigo is not a diagnosis. Okay, vertigo is a symptom. Okay, and unfortunately, we have a lot of people treating it like a diagnosis, and it's driving me crazy. Okay, so so we're gonna talk a little bit about that today. But like you mentioned,
What's the difference between the symptom and a diagnosis?
So a symptom is just something that you feel, something that is like off with a person, or it could be a clinical finding, right? Something that's not normal, but the underlying reason is the diagnosis. So the problem we have now is a lot of people anytime they hear vertigo, they equate it to a disorder called BPPV. Some of you have probably heard, right? That's one disorder that can cause vertigo, okay? But that is not the only, there are over 25 to 30 different vestibular disorders that can cause dizziness or vertigo. And our whole healthcare system and infrastructure is set up to treat one right now, pretty much. And even within this diagnosis of BPPV, there are different types, right? And even that.
Wait, what you saying? B or
BPPV. Yeah, yeah. And I'll break that down in a second. BPPV, benign paroxysmal positional vertigo. Yeah. So, but anyways, so I like to ask that question because I like to really establish that first. And then in terms of prevalence, okay, 50% of people will experience some form of vertigo by age 70. Okay, so half of us in this room all have that to look forward to. But let's define vertigo really quickly. Vertigo, all vertigo means is it's an illusory sense that something is moving, whether it be you or the surroundings, when in fact they are not. So a lot of times when people say vertigo, they're always equated to rim spinning. Drives me crazy. Because I had a patient tell me once, they told their doctor, hey, like I'm feeling off, I feel like things are moving when they're not. Am I experiencing vertigo? And the doctor says, oh, it's not rim spinning, it's not vertigo. Right? No, that's not right. Okay. Vertigo can present very differently. Typically, for the condition we talked about, BPPV, it is typically a rim spinning. We have other disorders, like we have a disorder called 3PD, and with that disorder, it feels more like a rocking or swaying. And then because it can present so differently, it's not uncommon for people to feel it in their body as well. I feel like I'm moving when I'm not. I feel like there's swirling in my head. I feel disembodied. These are all great examples of vertigo that is not rim spinning.
Be a lot of these using the medicine that you're taking to it.
Yeah, if you take too many medications, they can increase your risk of dizziness and vertigo. So like I mentioned, our healthcare system currently is not really set up to get these patients to the care they need. And so actually what's happening is for most people with vestibular disorders on average, it takes them about 5 to 6 different providers before they find the right person. So imagine how frustrating that is, right? Especially in our current healthcare system, seeing doctors, 3-month wait, 5 different providers, 6 different providers, right? You're looking at over a year before people get to the right place. It's a big problem. And we know if people get treated sooner, the better. Okay, so going on into treatment. So how do we look at these? How do we go about treating all these disorders? And then, so with headaches and dizziness, like I mentioned, they're both symptoms. And what we really want to look at is actually we want to look at function. So it's not even necessarily the diagnosis. The diagnosis gives us a lot of information. But even with the same diagnosis, many people can present differently, right? So basically, I think along 4 systems. These are the systems I'm always thinking about whenever I take a patient on. I want to look at their vestibular system, so how their inner ear function is. I want to look at their visual system. How are their eyes working? Are their eyes moving appropriately, conjugately? I want to look at the neck, right? And then I want to look at something called autonomics, like we talked about the whole body. So autonomics is refers to the automatic processes of your body that aren't under your conscious control. So think like blood pressure, heart rate, stuff like that, sweating. You don't really have conscious control with these things, but these are automatic processes in the body. Now, with a lot of these headache disorders, dizziness disorders, vertigo, vestibular disorders, what happens is that system becomes dysregulated. And then so we have people, diagnoses you might have heard of things like POTS, where people's heart rate, when they stand up, it increases too much, their blood pressure drops, or maybe their brain isn't dilating and constricting blood vessels appropriately at the right time. And with all this stuff going on, it throws the whole nervous system into dysregulation. They'll have, excessive sweating or not sweating at all, stomach issues, right? So the thing we have to remember is that these are whole body disorders, and we always need to be taking that into account whenever we see these patients. So let's start with the vestibular stuff. So vestibular, we're looking at the inner ear and the brain. And then so when we talk about vestibular, a lot of times people will start thinking inner ear. right? But the vestibular system is a little more comprehensive than that. So the vestibular system, to oversimplify it, is you have your ear, and then your ear receives balanced information, and then that information gets sent to your brain. Then your brain takes that information and integrates it from all the other sensory processes in your body to spit out your sense of balance. Does that make sense, everybody? Yeah.
Being my ear, nose, and throat guy,
Sure.
because I was getting dizzy, I probably doing,
Yeah.
and then I didn't want to, just getting, like, I was sick of my nose, and she told me it hurts, but it's, I've been having these, I've been having these dizzy things, and so that's part of it, see, that's what it is.
Yeah. Yeah. Let's check in about that a little later after this. Yeah, I'd love to hear more about it. So everyone has heard probably that your inner ears have something to do with your balance, right? Okay, so my question is this: do you guys know why that is? How does that work? Like, we know our eyes keep us oriented, right? How do your ears help you keep you balanced and oriented? Does anyone actually know the
Where
mechanism?
your vision comes from.
Sort of, yeah. So your inner ear, their job, you can think of them as two little gyroscopes on each side of your head. Their job is to tell your brain where your head is located in space. Where your head is located in space, how your head is moving, accelerating, in a relative to gravity. That's its job. Okay. And then so let's take a quick look here. So this is an inner ear model called a labyrinth. And then this is actually what you have in your inner ear balance structures. It's about this big in your life, and it's encased in your skull. Okay. And then so you have the inner ear model, and it sits like this. You have two of these. One on each side, obviously. And then so two structures we really want to be thinking about when we look at here. So I know most of our listeners here, they really let's backtrack a little bit. Remember how I said how like the vestibular system is the inner ear picks up information and tells you your brain where your head is oriented in space, and then your brain takes that information and spits out your sense of balance, right? So we have two places, and we can have issues happen at each side, right? So we can have dysfunction with the inner ear. Maybe your brain is working okay, but the dysfunctions with the inner ear, your brain's not getting accurate information. And then you can experience dizziness or vertigo. Or the ear is fine, and then it goes to the brain, maybe with a brain injury, right? Concussion, other neurological disorders, multiple sclerosis, doesn't process that information correctly, and then it makes you feel dizzy and have vertigo, right? So I know most of us today listening are probably people living with brain injury. We're thinking more, we call central disorder versus peripheral disorder. Thinking more of a central cause for the dizziness or vertigo. But I still really want to spend a fair amount of time talking about the ear and peripheral disorders, because people with brain injury are more at risk for developing this as well. And it's not uncommon to see multiple things going on at once. So we really want to spend some time on this. Okay, so this is your inner ear, and then you have you see these three canals. These are called semicircular canals. And your semicircular canals detect rotation in space. Okay. Rotation this way, rotation that way, up and down. That's what they do. Okay, and the way it works is in each canal we have fluid. Okay, you see the fluid? And then when you move your head, the fluid flows in the canal. And then at the end of the canal, there's a little hair cell, brushes up against that hair cell, and that tells you your brain is moving, your head is moving, right? Does that make sense? Questions about that? So with the disorder we call BPPV that we talked about, what happens in that disorder is there are these, in this big gray block, these are called otoliths. We have these calcium carbonate crystals. Okay. And then so those calcium carbonate crystals, for whatever reason, they fall out and they end up in a canal, and you'll see these color. Yeah, we call them otoconia. And then when that happens is they cause excessive movement of the fluid, right? So it's causing extra movement of the fluid. Your ear is telling your brain you're moving more than you actually are, right? And then that mismatch creates dizziness or vertigo. So when you guys were kids, did you ever spin in circles until you got dizzy? Yeah? Okay. Yeah. So what happens is when you do that, you spin and you spin. When you do that, the fluid starts picking up momentum, picks up inertia. And then when you stop, you're not moving anymore, but the fluid is still moving in the inner ear. Okay.
Getting off the teacup, right? It doesn't.
Yeah, it just keeps moving, and then that's why you get dizzy.
Mhm.
So, like I mentioned, the crystals end up in the canals, and then what happens is that makes you dizzy. Okay, because it causes excessive movement of the fluid. And then has anyone here heard of the Epley? So this is what BPPV is, like disorder I talked about. And right now, our healthcare system, a lot of healthcare workers are equating any form of vertigo to this disorder. But we mentioned earlier, there are 25 to 30 different disorders that can occur. And then there are 3 canals. And these canals are all oriented differently in space. And there's a maneuver that everyone is prescribing for vertigo. It's called the Epley. And the Epley only treats one canal. Okay. But there are 2 others. Total of 6 canals on both sides. So what's happening is everybody, I hear it all the time. They tell their doctor or whoever, hey, I have vertigo. They say, go home, do the Epley, whenever. And maybe crystals aren't in this canal. Maybe they're in this canal, right? So it's just going to make them feel worse. It's not going to do anything. And then what if maybe they have a central disorder or another inner disorder? Yeah, and it's not going to do anything. It's not appropriate. So we need to be testing appropriately to see if that's true. And then so the way we detect if that's happening is we actually look at eye movements. Because your eyes and your ears are coordinated. When you move your head, your eyes need to move the opposite direction to keep images stable. Does that make sense? So if you guys all stick out your thumb here, and you stick out a thumb, keep looking at your thumb and then turn your head to the right. What do your eyes do? They keep it in focus. So no, keep looking at your thumb there. Yeah, and then keep looking at it, turn your head to your right. Keep looking at it. Which way do your eyes move? Yeah. They move to the left.
Oh, see, I didn't see that. I'm still looking at the thumb.
No. So you're looking at the thumb. You turn your head right. Or
but you can see that I'm turning.
Yeah, but your eyes have to move the other way to keep it in focus. You know what I mean? Okay. Yeah. So what happens is when someone has the disorder and we put them in a position that causes the crystals to move, we'll see the eye movement. So let me show you guys what that looks like. Here. Hopefully we can all see that. So let's see. This one is a great example.
Thank you.
You see that? See how it twitches up like that? Yeah.
Oh wow.
So we're looking at the direction and the movement. So this one is beating up and it's rotating. It's rotating to the right, patient's right. So what that tells us is when it's up, what's up? Oh, it's stretching. So when it beats up and it rotates, that tells me it is actually this posterior canal right here. And for that person, yeah, the Epley makes sense. Okay. And then what the Epley does, the way we treat it is actually we just move the head through a series of maneuvers. And then we get the crystals all the way around the canal back into the gray block. And then the problem is effectively solved. Okay. Yeah. They can.
Just a movement happens, moves all the time.
Yeah.
She was stuck in the yard and she had to crawl to get to the thing. And what they do is just move it upside down. I think there's something else wrong with her. Yeah. Because I just make it upside down. I really can see where that don't know. See the context. See the context.
Okay, but we're gonna look at this place here, so you'll see. So, sorry. Okay. So hopefully you guys can see this one's a little smaller. Sorry. Okay, will you see this one? Can you guys see that? You see how it's not upbeating torsional? You see how it's purely horizontal?
Yeah.
That tells me it's this canal. Okay, that tells me it's this canal, not this one. Okay, so that's kind of what we do to, yeah.
So you have different movements for each canal.
Correct. Yes, and I'm gonna, so why don't we have Cynthia, can we do that demo?
James.
You can just sit on the table. And so I'm gonna use these goggles here, kind of capture the eye movements. Now, I'm sure some of you have heard of Dr. Ian Purcell, right? These were developed by Dr. Ian Purcell. They're no longer on the market because they're only compatible with iPhone 6. So I literally bought an iPhone 6.
Oh wow.
Yeah. They're actually probably my favorite pair. And then the battery of iPhone 6, it dies super quick, so I have to turn it off and turn it on every time. So we're gonna let this load. Okay, so while we're doing that, I'm going to show you how I test for posterior connect. Okay, so you know how I test for posterior. Okay, so traditionally, most clinics, the way they do it is like this. I'm going to show you. So you can bring your legs up this way. Yeah, okay, yeah, a little more. All right, traditionally, the way they do it is they call it a Diggs Hall button. Okay, so you turn your head this way, testing the right ear, and then you're just going to lay back. Head's going to go over the edge of the table. Okay, I got you. I got you. I got you. I got you. Okay. You okay?
Yeah.
Yeah, okay, you can come up. Okay, that's how they typically do it. I'm gonna show you my variations because I'm a mobile PT. I do a lot of sideline variations because guess what? I don't always want to lug my table in. So then I can just do it on the couch. Okay, but that's how they typically do it. So I'm gonna show you my variation. So why don't you just go ahead and you can scoot your legs over. So we do a sideline variation. So we're gonna do, let's turn your head this way. Actually, let's do the other way. So we're gonna go this way with this, and then this is, we call this a right sideline Diggs Hall leg. So you're just gonna lay down on the shoulder for head and you take it 1, 2, 3 down. Good. You guys see that? Okay. So you okay?
Yeah.
Okay. So you see how this position is similar to how it was just off the table, right? I can just do this on the couch. It's a lot more comfortable from this table. And then if I had a positive test for this canal, what I would see is I would see the eye move up and turn towards the affected ear. So this is positive, it goes up and to the right. Okay. And then if that's positive, then we can treat it. So traditionally people use the Epley. I'm sure some of you tried it. I prefer the Smont because like I said, I like being a sideline. So I should have walked you through this earlier, but we got it. Okay, so stay here. What you're gonna do is you're gonna push off here and keep looking over the shoulder.
I push off of this.
Yeah, and then you're gonna keep on, I'll guide your head, you're gonna come over and then you're gonna kind of keep looking down this way. Okay. And I'll protect your forehead so you don't slam your face into the table. Right? Ready? 1, 2, 3, down, all the way over. Good. There you go. Okay. So the crystals get guided through that canal over to the other side. Okay. Yeah. Okay. We're lucky she didn't throw up, so
What happened?
no, not really. It happens every once in a while. Then you can come up chin to chest. Retest. Okay, retest, and she's good. Okay. All right. So that was posterior canal. Okay, so let's go into horizontal. Horizontal is much more involved. I do not recommend anyone try it on their own. So typically the way they do it is they have you lay on your back, you turn your head one way, you turn your head the other way. I'm working off the couch, so what I do is let's do the Diggs Hall like again. So I this. So turn your head this way, and come down on the shoulder. 1, 2, 3, good. Okay, so say we're looking at this is the posterior canal. And I don't see a positive test. Okay, from here, I can go ahead and look at the horizontal. Now here, all I do is I'm over here. I'm usually in front looking at her eyes. Take her head, blow it back. Now I'm looking at the horizontal, and then I'm looking for the eyes are being up or down, towards the ground, towards the ceiling, and then you go back up. And then with horizontal, you have to make sure you test both sides. Okay, because we want to be looking at the direction of the eye movement. And then we can treat that with the appropriate maneuver. Does that make sense to everybody? Any questions about that? Okay, so we're just going to talk through it a little bit. Why don't we look at it? Let's take a so, and let's see if I can do this. So I'm just going to do pretend. I'm just gonna keep playing this so you guys can kind of see. So this is basically a video of me tracking the eyes to what we just talked about. And I just want to show people, kind of talk to people about how complicated horizontal canal can be. Or I don't expect anyone to remember this, but I just want to show you the kind of 3D chess us therapists have to play when we look at horizontal canal. So here I am, I link here. Okay, I'm turning this way, looking for eye movement. Let's say I see the eye movement beating down to the ground. Come this way, go the other way. Okay, I see the eye movement beating down to the ground. We call that a geotropic nystagmus, geotropic eye movements to the ground. And then when we do that, the side with more symptoms or a stronger beating of the eyes that we call nystagmus, that's the affected ear. Okay, that's the affected ear. But if I go this way, and then I go this way, and I see the eyes beating up to the ceiling, okay, the side with less symptoms is the affected ear. Does that make sense? And then using that information, you have to determine which maneuver to use. So it gets very complicated very, very quickly. So that's just an example, right, of how BPPV is a much more complex disorder than people realize. There can be variants, right? They're not always the same. It's not always this canal. And even within the canal, there are different variants. And just telling everybody to go home and take the epilepsy is not proper care. Yeah. So, all right, thank you very much.
The question, how would survivors be able to advocate for this to be done?
For this test, well, honestly, at this point, I think the best advice I would give is just tell them for referral to vestibular therapy. That's probably the best. Yeah, vestibular therapy, just vestibular therapy. Okay, so we talked about canals, and then the canals are what get the most attention in vestibular rehab. Pretty much everyone is talking about canals and this disorder, but we're actually missing a big piece, and that's this big gray central block. These are called the otoliths. And what your otoliths are responsible for is linear movement. So horizontal, these otoliths that are turning on and down, like you're moving. So thinking in a car, walking side to side, walking, right? Canals are angular, otoliths are linear. And then also up and down, like this, like riding an elevator, that's also your otoliths. So how do we test it? How do I test the function of someone's otoliths? How do I say that something off there? The gold standard test for that is actually something called a VEMP. And VEMPs are done at audiology offices or ENT offices. But guess what? Reimbursement rates for VEMPs have become so low, they're just not worth it anymore for any clinic. So most clinics are just not opting to do them anymore. So you're going to be very hard pressed to find someone who can do a VEMP for you. Now the VEMPs are pretty much isolated to the major hospital systems like UCSD, and we all know how that goes. 8-month wait, 10-month wait, 12-month wait, right? So how can I test that immediately? And I'm going to show you. All my volunteers left. Well, can I have you volunteer? Madeline, right? Okay. Can I see that again? So we're still looking at the inner ear. This is still peripheral. Okay, we'll get to the brain stuff. Okay. So my bucket here, I made this myself. Okay. Then we have a glow in the dark tape inside. So the patient's head goes in the bucket, like so. Starts turned. And we slowly rotate it. And I want you to tell me when you think it's straight. So we're testing your ear's ability to tell your brain how are you oriented in space, right? Because if these otoliths are damaged, maybe you think you're leaning this way. Maybe this feels like a straight line, midline for you. Right? So I'll just kind of do the camera here. So we start here. And we go, tell me when you think that line is straight. And then on the back, I have a protractor. I'm measuring off the yard. Okay?
Oh, it's the line, and tell you when the line is straight.
Yeah, I'll tell you when the line is straight. Okay, you ready? Go ahead and close your eyes for me. Okay. And I'm just gonna do it.
You don't know my eyes closed for this?
Eyes closed for now. Yeah, I'll tell you when to open. Okay. Eyes closed. Okay. You can scream as loud as you want. Okay. Go ahead and open your eyes now. Eyes are open?
Mhm.
And tell me when the line is straight.
Fine, yeah. Well,
Yeah, very good. Yeah, we're good. Okay, so we would test both sides. That's how I test for your otolith function without like a $300,000 piece of equipment. Okay, and this is a scientifically validated test as well. Okay. Hey. Okay. Thank you very much. Yeah. Oops. Okay, so I'll stick around a bit after. You guys are welcome to go and try this bucket. See how you do. Any questions about all that so far? Okay, so let's talk about. So we talked a lot about the inner ear just now. So now let's talk about the if in the presence of a central disorder. Because most of us here are dealing with central disorders, brain injury, but well, one thing I should mention is if you get hit in the head, the side of the head, what can happen is actually it can damage these structures as well. We call that a lab. So I know we have different varying degrees of brain injury in here. I primarily work with concussion, so kind of less one trauma, but I just want to show people what happens in a concussion. So I know people can't really see. So you guys see that? So basically, think about your brain as like a piece of jello, big piece of jello.
mhm.
And then when it moves back and forth quickly with a concussion, the jello wobbles, right? Jello wobbles. And then when the jello wobbles like that, maybe the top part of the jello is going this way, bottom part of the jello is going this way. And when that happens, it puts stress on the neurons and it damages the neurons all over the brain. Okay. But it happens on a cellular level, so you can't see it on imaging. You're not going to find it. Okay. So it's really diagnosed off history and clinical tests. Okay. So the history and clinical tests. So that's what happens. And then when that happens, is basically it doesn't matter if your ears are fully intact or not. Your brain just isn't processing that information. Okay. So
Yeah.
concussion is an example, and I'll kind of show you what we do for that. And then also, you remember how I talked about how different eye movements tell us different things? And then so people with vestibular migraine or other central disorders, what a lot of them will present with is something we call a downbeating. Downbeating nystagmus. So I'll show you. Where you guys see that?
Mhm.
See how it beats really vertical. That's a very clear central finding that tells me there's something going on in the brain. Refer to neurology. Okay, rule out everything. If they're safe to continue, come back to therapy. We'll keep working. Yeah. Okay. Let me do one more test for you guys. So one way we can really tease out what's happening is with the balance test. So let's just bounce right into it.
Yeah.
So a couple different series of tests we can do. So why don't you stay with your feet straight here?
That's what it's.
Not on the phone pad first. Together. Okay, then eyes open for now. So right now, she has multiple systems working for her balance. She has her inner ears, right? Her inner ears are telling her head is still. Her feet are telling her where the ground is, right? And then her eyes are telling her where she is in space. And then so we're thinking along these three systems. All right, so everything's pretty easy for you.
Yeah.
Okay, let's close your eyes. And now she closes her eyes. She can't rely on her eyes anymore. We took that out of the equation. Now she's relying on her inner ears. Okay. And now open. And let's head on the phone pad. Bring your feet together. Okay. Now close your eyes. So now she doesn't have can't rely on her feet, can't rely on her eyes, she has to rely on her inner ears. And then my job as a therapist is to, with my clinical examination, I can't go through all of it today, to determine if it's actually the inner ear or it's just the brain not processing that information correctly. But this is how we can tease out how much of it is actually coming from here. So this looks great. You know, if you has a bit of sway, really normal. But some people they fall right over. Okay. All right. Thank you.
Wow, that's cool.
Yeah.
I was like, maybe my
And
balance is wrong.
if you fall right over or have real problems with balance.
Yes.
Does that always indicate it's the ear or could it have been something else from the brain injury?
It can be either, and it can be both as well. So
So
I
if
don't,
I did that test and I really had trouble,
yeah,
I mean, I wouldn't fall over, I don't think, if I had trouble standing.
yeah.
Would you also recommend me at this point going to see somebody else to clear the other possibilities rather than the inner ear that are causing you to be unbalanced?
I don't think so, because you're followed up by a physician. I'm assuming.
Right,
I don't think you really need too much testing
okay,
unless something new pops up or
I
I
was
find
curious.
I find something on
I
exam.
was just curious, okay.
Yeah, yeah. So yeah, I mean it all just depends on examination, you know. We're always, you know, I don't think people realize when it comes to therapists, there's a lot of thinking going on our head about what should be done, but we're also thinking about what shouldn't be done as well.
Yeah,
We do a lot of screens, make sure that there's nothing more sinister going on. Okay. So, yeah. But I actually really want to highlight something is that a lot of these tests that we do in vestibular physical therapy, they are very different than the tests they do at the doctor's office.
Yeah,
And the tests we do are pretty much, I call them like field tests. They're tests that are done in real space that relate to real movement, right? We have these tests like BNGs, BEMS, you know, it's all based on electrical activity. They stimulate the ear and they say, oh, is the electrical activity normal in the face, all that stuff. Right? How much does that mean to the patient, really? Versus my bucket, right?
yeah.
I put your head in the bucket. It's like, hey man, you're 15 degrees off. You don't know where straight is. What's more valuable? You tell me. So, anyways, that's my little soapbox. Okay, so I think this can lead us naturally. We can segue into vision, right? We talked about 4 different systems, so let's go into vision now. And vision is where we can really start to tease out whether we're dealing with a central or a peripheral disorder. So I'm gonna give an example. Something I use a lot is called the vestibular ocular motor screen, where I look at a lot of different eye movements. Different eye movements have different processes. Okay, and that tells me whether it's central or peripheral. So was it Layla?
Lali,
Lali?
yes.
Okay. Could I have you volunteer?
Sure.
Thank you. All right. So you know how to speak here. Okay. Okay, you ready? All right. So first eye movement I typically look at is something called smooth pursuits. Smooth pursuits was fancy way saying visual tracking. You're tracking an object without moving your head. Okay. So I always say, you know, they say the eyes are the window to the soul, but if you have a concussion, the eyes are the window to the brain. Okay. So here it is. You see the elephant? Here. I like to use a little elephant. I love my pencil erasers. Okay. So you see the elephant, and then so just track the elephant. Eyes. How does that feel for you? Feels okay?
Pretty good, yeah.
Pretty good. Yeah, eyes look nice and smooth. This is a central process. So if it's okay, but they're like, oh, it's triggering my symptoms. I'm really thinking central already. In more severe cases, what I'll see is the eyes can't keep up, or the eyes are not accurate. So I just had one yesterday. Right, they're following my elephant. Their eyes are jumping all around. They can't move it smoothly. That's the central process. The next one is saccades. I like to use my little sticks here. So they're really cute. I'll show the camera in a second. The little animals and stuff on there. Teddy bear. Okay. And so you see the cars? Look at one car and then the other. This is a process called saccades. Okay. It's one of the fastest movements we have in the human body. If you can jump like that. Okay. Looks good, looks nice and smooth. What might I see with someone who has a central disorder, brain injury? What I might see is they overshoot or they undershoot. They have to correct, call that a corrective saccade. Yeah, so that's giving me information that what needs to be worked on. So we do it horizontally, then we do it vertically as well. Okay. Next one we look at is something called you doing okay? Next thing we're talking about is convergence. So your ability to bring your eyes together, going cross-eyed in this direction. This very common after concussion. Yeah, very common after a concussion or with a headache disorder or vestibular disorder, central vestibular disorder, that people have trouble doing this. They have trouble bringing their eyes together. And what that translates to is you have trouble looking at objects up close. Trouble, headaches with the reading, headaches with screen time, headaches up with the computer, right? Because our eyes aren't working properly and they're not moving well, and the brain is trying to work with this information that maybe isn't coming in very good. Well, that leads to the headache. So the way we do that is so just keep your eyes on the open, okay? And then just tell me if you see double. So double being 2, but you see it split into 2. Tell me, start seeing double there. No? Very nice. Yeah, close, you know, yeah, okay. So let's just pretend that you see double and right here. Can you hold this for me? Don't move. And I come in here with my measuring tape, okay, and then I measure how far they are, and I go, oh my gosh, 20 centimeters. I should be at 6 centimeters. Okay. And that's how we can tell with convergence. And then I do want to say, so now that we're talking about vision, I want to be perfectly clear that physical therapists, we are not vision therapists. We aren't neuro-optometrists. We aren't FCOBDs. But what does fall into our practice is still looking at coordination of our tool set, right? And some of these other eye movements as well. I do want to be clear that, you know, our tools that we use for doing this are probably pretty crude compared to what, you know, an FCOBT or a neuro-optometrist can do. But a lot of times, you know, people come in, we come in with this vestibular stuff, they come in with different stuff, come in with next stuff. There's a lot going on. If the vision is not too heavily impacted, right, as much, it's not the primary driver, that is something that most of us can probably handle. Okay. So we did convergence, and then so next one is something called VOR. So just stick your thumb out here. And can you turn your head from side to side? Keep that thumb in focus for me. No, like this one. Yeah. Yeah, you gotta keep it in focus. Okay, that's a peripheral process. So that's more looking at the integrity of the inner ear, or your inner ears, as your head movement and eye movement coordinated. Okay, that's a peripheral process. So it starts to blur or it starts to double while you're doing that. You can't keep it stable. That gives me a fair amount of information as well. Okay. And then last one is visual motion sensitivity. So you can just stand up for me. Or VOR cancellation. Hands up this way. Okay, go like this. Keep the thumb.
Thanks.
Yeah.
Oh, both ways?
Yeah. There you go. No problem. Okay. Yeah. So this is also a central process. Okay. When you turn your head, the natural reflex is for your eyes to go the other way. That's what your eyes want to do. But if you want to keep this low in focus, you have to suppress that reflex. That's done from the brain. So think about baseball players, right? If they're trying to keep track of a moving object, they need that VOR cancellation response to be intact for that to work. So after a concussion, maybe this gets impaired, right? Their eyes are kind of jumpy when they're trying to track a baseball, and then they have issues. And then we have one more. You can sit. Right. And then another thing I like to look at is we call it optokinetics. So basically seeing how people's eyes respond to a moving stimulus. And then a normal test is actually, do you want to see some jumping? So this is about off the ground. I made this myself too. I made it with a lazy Susan, some craft foam and some tape. And then just look straight ahead for me. And just count the stripes, all right? And then I'm looking at our object. You guys can't see from over there. But you can kind of stick around and try later. Our eyes are jumping like this, going this way. And that's normal.
Okay.
So I'm looking for asymmetry. Asymmetry on each side. Okay. Right. Does that make sense to everybody? Yeah, okay, so what are some exercises we can do? So let's start with smooth pursuits. Okay, visual tracking. So what's an exercise? So we could practice following a finger or whatever, right? Pretty boring. So let's try couple of announcements. So yeah, I got out your advice. So yes, sir. So this is called a Marsden ball. Maybe you may have seen it before.
You know what I'm saying?
Yeah, I do it all the time. Okay.
No, maybe it's what's there.
Yeah. So with the Marsden ball, we're working on smooth pursuits. This is pretty fast for a lot of people, right? And so you can just keep your eyes there. Nice, and that's tracking beautifully. Can you name out letters? As you see them?
G, P, Y, I, C, S, N, M,
Okay. So pick one letter first. Just name one letter.
B,
Okay. Can you tell me where this starts with B?
Bear,
Yeah. Can you spell it for me?
B, E, A, R.
Okay, good. You see how we layer on that cognition? It makes it immediately.
Oh,
Makes it
that's
immediately.
typical.
It makes it immediately harder, right?
Yeah.
And she's sitting down. So what if she was standing? I've had her spell it backwards. It's very difficult very quickly.
Yeah.
Now let me show you another one. That I like to explain. You can stand over here. We're pretty nice. Why don't you stand on the foam pad? So you can get that forward here. You basically. Yeah. Don't fall.
Yeah.
Let's go feet together. And then another way we can do smooth pursuits is we find out. I call this my Vistarilla. So I have an umbrella here, and I just want to. My goal is to tape on some stuff.
Hey, you have to say sending it very.
Yeah.
So you can go ahead, pick a target, and just follow it.
Okay.
Yeah, I can change directions. I can go if I want to work on that convergence or divergence piece. I can go in and move out. I can have her doing it walking. I can have her doing it while moving her head. Right. So you can keep the target, focus on a target, move your head. There you go. Layering on different processes. So it's really important as we get better and better that we start integrating everything. You don't want to just be working on one neurological process, right? Because that's not how real life works. There's a lot of different things going on at the same time.
This is the therapy portion.
Yeah. So if I know someone has issues with smooth pursuits, then this is kind of later stage, something I can do with them. All right. And then, with this one, like I talked about, we were talking about how I was looking at the eye movements, and it can be normal, but some people, it can be after a brain injury, it can be very triggering. It can be an issue. And that's when we hear things like actionable in grocery stores, trouble, and this could be a treatment as well. So I literally just have a fun, I could spin it, we can practice, but that's a way to do it too. All right. Let's see what else I want to do. Let's do one more. Let's do two more. I think one. Everyone keeping up okay? I know it's kind of all over the place. Keeping up okay. So, all right. So we talked about convergence insufficiency, having trouble bringing your eyes in. We also divergence, having trouble bringing your eyes apart. This is when I hear people complain. They get dizzy and disoriented in open spaces. I get headaches when I drive, looking in the distance for long periods of time. Okay. So go ahead and sit. And then one thing I want to be very clear about is sight is very different than vision. Sight is when you go to the optometrist, they look at the physical health of the eye. Okay. Structurally, how is the hardware of the eye, right? Are there cataracts in there? What's the shape of the eye? Is there any astigmatism? Right, that's their job. Vision is different. Vision is a whole neurological process. You have two cameras, they have to move together properly. Guess what? You have two cameras, your eyes are actually taking two pictures, two different pictures. Pictures get sent to your brain has to merge the pictures to get what you see. And one interesting fact is, when you look at a picture, the image that gets reflected in your eye is actually upside down. Your brain takes that information, flips it right side up. Okay. So let's do a quick demonstration here. I want to show you just how powerful that merging is. So if we take, some of us are going to have a little difficulty with this, especially but let's just try. Why don't you take one finger far away? Then you take a finger up close. And so can you focus? Let me see. Gotta focus.
Focus.
Focus on this finger.
Oh, focus.
Okay, and then while you're focusing on this finger in the background, what is this finger doing?
It's blurred.
You see two?
Yes,
You see two?
I do.
You see that? Okay, your brain is focused on merging this. It's like saying, oh, let's keep this combined. I don't really care about too much else right now. So the finger in the back doubles. That's normal. Okay. Now let's do the other way. Why don't you look at this one?
Oh, it's still like.
Yeah, look at this far one. Look at the close one. I mean, look at this far one. Look at this far one, and then while you're focusing on that in like your periphery, what do you see the far one do?
Yeah, it's kind of like.
Is it double?
There is double, yeah.
Yeah, it's doubling, right? Yeah.
This one is going.
So whichever one you're not focusing on is going to change.
What if it doesn't though?
Then yeah, maybe there's convergence or divergence insufficiency. And that can be multiple ways. Maybe the eyes are moving together properly. And then where you want to get more to vision therapy and stuff, maybe the brain's not processing that information correctly. One thing that can happen is if there's like that issue going on, sometimes what your brain likes to do is it'll suppress one eye. It'll just shut off one eye because it just can't handle it. And then when that happens, things don't double when they should. Which is a weird thing to say, doubling is normal in certain circumstances, right? But if I go in like this and then she starts doubling out here, that's not normal. Right? She should be able to keep it as one inch. Right? So
Okay.
let's talk about divergence insufficiency. And so so this is called a Remy separator. Y'all can say you can. Okay, and this is for training to bring your eyes apart. And so you hold it like this, relax your gaze, imagine you're looking through the paper, and then if you do it right, the circles will become one. Okay, will become one. You gonna try?
So like focus.
So yeah, well, right, your nose there, it's split in half. Okay, and then imagine you're looking through the paper, and my fingers here. What's happening to the circles?
They're getting close.
They're getting closer.
Yeah.
Okay, so let's do the second from the bottom. Can you get it to become one circle? So how I try the bottom? What about the bottom?
The bottom one is definitely.
Okay, it's one.
Yeah.
Okay, so get it nice and clear.
Okay, I got it.
Okay, you see the letters around the left wrap? Focus these words.
Yes.
Okay, what's happening to the letters? Are they popping in or out? Three-dimensional, do you see it?
I don't know how good this right.
Yeah.
This feels really weird to
Yeah, I can definitely like see the letters popping out.
Yeah, okay, so if you do it right, the image starts becoming three-dimensional, actually, the way.
maybe wearing the wrong glasses.
Yeah.
Oh, yeah, like wrong glasses.
So that just goes to show just how much your vision is actually kind of being how your brain is processing
Yeah.
imagery, right? Because this is obviously not three-dimensional, but when you practice, it becomes three-dimensional. All right. Okay, so we talked a fair bit. Looks like I am gonna go the full 2 hours. Okay, so we looked at vision, we looked at vestibular and ear function, we looked at vision. Now let's look at the neck thing. So I think most people have a pretty intuitive understanding. Physical therapists work with the neck. If you're dealing with dizziness, headaches, vertigo, it becomes extra important to do that, especially with our vestibular patients. If you're dizzy or you have vertigo, guess what? You don't like moving your head. You don't like moving your head, neck gets stiff. That doesn't help the situation. It can feed back into it. So I'm just going to show you guys 2 tests that I like to do. So, Jules, and you get headaches, right?
I do.
Okay, well this is going to be a fun one. Can you just let me hear that?
You have to drive on? No.
Just bend your knees. Just like you want to just bend your knees up so you don't keep my stuff. Good. There you go. Good. Yeah, from. You need to get down a bit. Okay. You okay?
Yeah.
Okay. So one really important thing for the neck is we want to be looking at, we call them deep neck flexors. These are muscles that are deep to these big neck muscles up front. Now what the deep neck flexors do, they're responsible for stabilizing the spine. Okay, so they're really important for the muscles to strengthen. And what happens is when you have a neck injury, actually, for whatever reason, those muscles actually get shut off. They turn weaker, become more dependent on these large muscles on the outside, and then that's not good. So the way we test for that, the way that I test for it, so can you make a double check for me? Not too hard, just a little bit. Yeah, good. Okay, so that's activating the deep neck flexors. And then in a second, I'm gonna ask her to lift her head up. And once the head comes up, I'm gonna be timing how long can you maintain that double chin. I'm looking at that skin fold. Once it separates, test terminates. Okay, you ready? Okay, go ahead, lift your chin up. We're looking at that skin fold there. Already, she's trying to spill there. Okay, there you go, about 9 seconds. And for women, we want it around 35, okay? And we want it around 40. I was being extra strict too, so don't worry. And then so that's a great way to test it. And I just want to show a variation. So we're gonna do the same thing, but can you do it with your mouth slightly open? Okay, and then double chin first, and then go up. Don't lose that double chin point. Is that harder or easier? Harder. Way harder, right? Okay, that's all. So the reason that becomes harder is because when you open your mouth, it kind of deactivates what we call the sternocleidomastoids in front. So you can't be as dependent on the big muscles around your neck. You have to really rely on the deep neck flexors. Okay, and then after that, we want to do a fair amount of strengthening and stabilization work too. Okay, so strength, that makes sense. And then let's also take a look at proprioception. Are people familiar with that term, proprioception? No? Okay. So proprioception just means, Jules, you can sit up now. Okay, well, I'll just demonstrate proprioception for you. Okay, can I grab your arm? Close your eyes. Okay, am I moving your arm up or down? Okay, am I moving your arm up or down?
Down.
That's proprioception. Okay, your body's ability to know where it is in space. So after a neck injury, a lot of brain injuries, guess what? They come with neck injuries. Okay, takes 19 G's of force to cause a concussion. Takes 4 G's of force to cause a neck injury. Okay, so they pretty much always come together. And then when it happens, when your neck gets sprained, it impacts the proprioception. Okay, but how do we test for proprioception over that? Let me do that. If I can find it. Okay. I'm gonna throw this on me. Here, over here. Okay, we got the checking one, I'm sorry. They're all being loaned out to my patients, so. So, over. It's a little tight for you.
I got a big head.
Alright, it's good enough. Okay, why don't you stand here facing me? And, yeah, okay. So, we have a target here. I'm gonna try and slide. You see the laser? You can tilt this down a bit. You okay? Next, so neutral position. Also not for you. Okay, there it is. You guys want to? Can you guys see?
Hmm.
So the laser's on the target, and then let's do. Close your eyes. Turn your head all the way left for me, and close my eyes so it won't blur my eyes. Okay, and then keep your eyes closed. Bring it back to center. Where you think center is. Okay, and then where you think is center. Open. Okay, so that's the way we can test for it. All right, so if your neck doesn't know where it is in space, guess what? Your head's gonna have trouble knowing where it is in space too, because you know your head sits on your neck, right? So just for reference here, okay, so this is where we want her back in when she comes back, and then she was about over here. All right, so that's the same one. You did. So when you have chronic neck pain, headaches, this really gets impaired in a lot of people. That's something you want to look into. All right, cool. Okay, we're gonna move on to the next. Okay, so the fourth and final piece that we really want to talk about is autonomics. Yeah, so autonomics, like I mentioned, is these automatic processes of the body, right? So when you go for a run, right, if you go for a fast walk or you exercise, what's normal is your heart rate goes up, blood pressure goes up, blood vessels dilate, in certain areas constrict in certain areas, right? But with a brain injury, with headache disorders, with vestibular disorders, this all gets impaired. Vestibular disorders and autonomic function, they go hand in hand. You guys think about it. If your brain doesn't know where your body doesn't know where your head is in space reliably, right? That blood pressure regulation was definitely going to be on, right? Because maybe you're down here, but I don't know, your brain thinks you're up here, right? Right? Then what's going to happen is it's going to raise your blood pressure inappropriately, right? You see what I mean? Yeah. So think about how dialed in that has to be, right? When you do burpees, the body's amazing. It's like when you go up and down, it's constantly changing these like all these parameters, right? Your blood pressure, your heart rate, sweating, all this stuff. And then, but with these issues, that becomes dysregulated, and then people have things like exercise intolerance. They have anxiety, panic attacks. It makes it a lot more difficult to deal with. So we have a couple things we want to talk about with that. So the first thing I want to talk about is actually we call it exertional tolerance. How does this person respond to exercise? Very, very relevant for people who have concussions. Some of the best research we have is around this area for concussions. So with a concussion, they become dysregulated, right? So they start getting a lot of symptoms when they do physical exertion. So how do we want to treat that? Is we actually want to provoke the symptoms just a little bit so that their body can readjust so that they're responding to exercise appropriately. But I can't just tell my concussion patient or brain injury patient to go out on a 5K. That's not very clinical, right? This is a clinical problem that is a clinical solution. So the way we do it is we do exertional tests. And today, the one that I do is called a Buffalo concussion march test. Traditionally it's done on a treadmill, but because I work from home, that's what I do. So, all right, I need a volunteer who's willing to work a little bit harder.
No hands. Nobody.
I can't do it. I can't do it because my leg doesn't.
No, we'll have
Jill's.
we'll get. So the way the march test works is I'm going to play a metronome, and then with each click, I want you to bring your knees up about mid-thigh. Okay, yeah, and then it's a pretty long test. It's like 15 minutes. We're going to squeeze it into like 2 minutes. Okay, and then so every minute the pace is going to increase, and then with that increase, I'm looking at how hard are you working. I'm looking at your heart rate, and then I'm looking at how is it provoking your symptoms. And what we want is we want a baseline of the most important metric is this one. So 0 to 10, how bad are your symptoms right now? Like a 3. Like a 3. Okay, is that a 3 right now? And then so as we go through each minute, I'm saying, hey, can you tell me more? Can you tell me more? Once that number hits a certain threshold, 3-point increase, the test is terminated. That tells us the heart rate that issues are starting to happen. And we use that as a benchmark to prescribe exercise for her. So we take 80% of that, and that's what we're going to use for exercise, aerobic exercise program. Okay, you ready? You ready? Okay. Thank you for being a volunteer for this one. So we started at 120. We started 70 beats per minute. Okay, so we do this for a minute. Then 1 minute's over. You go to the next minute. Next here. A little faster. Minute 2. Minute 3. Minute 4. Minute 5. You can join in if you want. Minute 6. Each minute, I'm measuring our heart rate. How hard are you working? How are you feeling? I lost count. I think it's minute 7. Keep the pace. Keep the pace. Keep the pace. This is gonna be a little low.
How far do we have to keep?
Yeah. You okay?
Yeah, good.
Next minute. Next minute. Next minute.
Yeah, that's good.
Yeah, it's still going. Next minute here.
That's fine.
These minutes have now.
I think we're yeah, minute 10. Next minute.
Yeah.
You have to start running at this minute. Yeah. Next minute. Next minute. Yeah, then test is done. Nice job. Okay. So you can see how that's a pretty difficult test. It's a pretty strong test, and then for I think athletes, post concussion athletes, football athletes, pump experts. This is a really important test that we want to do.
She doesn't even look like she got a book.
Yeah.
I didn't look
Well, she
did, yeah. You didn't do a full 15 minutes though. Yeah.
So that's specifically relating to exercise intolerance, and then one thing we also want to be thinking about with one thing we also want to be thinking about with autonomics is we want to think about down regulation as well. Because I think nervous system regulation is becoming more and more of a popular topic, and it's really good. I think it's really great. So some of you may be familiar with breathing techniques that we like to use, stuff like that. And sometimes that doesn't necessarily work for everybody. So what are some different strategies that we have that we can kind of get this excessive kind of nervous system, energy out? And then, so what I really like to use is I actually really enjoy using fidget toys. So when you're dizzy, and then we provoke your symptoms a little bit during therapy, during your break, you can kind of use some fidgets and kind of like calm things down a little. So I think I left them in the car, but I use fidget spinners, I use stress balls, I use fidget rings. I did bring these. This is something I really like too. These are called infinity cubes. And the thing about fidgets is there's very good documented evidence that using your hands is good for brain function as well. Decreases the risk of, with like dementia or cognitive decline. And so these are something you guys can pass these around, try it out. I'll just show the screen really quick. So you can see how much they can just kind of feel it with their hands doing this. You can just pass it around. And then you can also use things like sound. So this is one I like. This is called an open drum, right? Very calming. Yeah. Yeah. And some, my vestibular patients, some of them feel like they're on a boat. So, at the ocean, maybe it helps a little. Yeah. So those are some techniques that we use as well for regulation. Yeah. And then, so those are the 4 major domains I'm thinking about. And then the other pieces that we're also thinking about that are a little less in my scope of practice is we're thinking about cognition as well. And we're also, especially with brain injury, thinking about cognition. We're also thinking about anxiety, right? Because anxiety really ramps things up. So these regulation techniques like great for anxiety. And then with cognition, pretty much with all these exercises I've done, you can kind of add on a cognitive task, layer that on top. But ideally, we want someone being seen by neuropsychology for cognition, and maybe a therapist or a psychologist for any anxiety stuff. But within therapy, I can address those things a little bit, right? So like with the Marsden ball, later on a cognitive test, or maybe, standing balance, right? I can stand on one leg. Maybe for me, that's pretty easy. And then as soon as I add on a cognitive task, like I have to start counting backwards from 7 by 7 from 115, 108, you see, immediately becomes harder. So that's something we think about too. As you progress through the stages, let's layer that on top. Okay. sometimes it's very clear, like, this is driving into that for sure.
Mhm.
Right? Like the neck pain, the vision issues, they're driving the headaches, they're driving into like excessive earring,
Mhm.
driving into dizziness further. But like I mentioned, these are bizarre disorders. Very weird,
Right.
right? And sometimes people resent with these weird things. And quite frankly, we just don't know if it'll help. A lot of times it does, but not always.
So,
Location, yeah, I do not have a physical location. I'm purely mobile. So I would come to your home. Mhm. Yeah. And I enjoy working in the home actually. I think you can really work on specific problems that you're having at home. Like, we have that setting grounded for us. There's a lot of work you can do that way too. And if you're dizzy, you don't necessarily like driving, so yeah.